having said all these things about the thyroid, I want to go over a couple of cases with you and see to make sure that everybody understands what we've talked about. So thyroid case number 1, a 27-year-old woman comes to your office for throat pain for 1 week and palpitations. So she's got throat pain and 1 week of palpitations. She has no prior history. She takes no medications. The blood pressure is 142/92, so it's a little bit elevated. The pulse is 112, it's elevated. The oropharynx is normal. The thyroid is painful and diffusely enlarged, so it's painful, but it's diffusely enlarged, so you question the diagnosis here. You don't know what's going on. The TSH is low. The free T4 is 14. This is elevated. So I'm telling you, this is usually the free T4. The upper limits are normal anywhere from 5 to 7. So this is elevated here. This is low right here. Less than 0.1. It's low. This is elevated right here, the free T4. And your radioactive iodine uptake scan is low. 3% is low. So what would be the next most appropriate test if you wanted to confirm the diagnosis? And you've already pretty much confirmed the diagnosis here. And the answer is, if you wanted to get one more test to show what this patient has, you may get an erythrocyte sedimentation rate to show that this is an acute inflammatory state, because what this person has is subacute thyroiditis. But the most appropriate next step here would be to treat the patient. If they ask you what's the next step, treat the patient with what? Pain medication, nonsteroidals, aspirin, and stuff like that. The test, if they're asking for a test, it's usually the erythrocyte sedimentation rate, to show that this patient has intense inflammation. But most people don't even have to do that. Once the radioactive iodine scan is low, that confirms the diagnosis of subacute thyroiditis. Again, this is a disease that goes away after a couple of weeks, some months or so, so you don't have to treat it with antithyroid medication. Be careful of that. Only symptomatic treatment. The next case, a 32-year-old man is admitted to the ICU, to the intensive care unit with delirium, is treated for presumed sepsis. Thyroid hormones drawn on the day of admission show a very low free T3. The TSH is normal. There is concern about myxedema coma given that he had a history of a thyroid nodule. Now, what did I tell you? What's the first test we look at when we're suspecting thyroid disease? We look at the TSH, and if the TSH is normal, I told you that this patient has euthyroid, doesn't have any thyroid problem. Now you're going to ask me, why does this patient then have a very low free T3? And what this patient has is this thing called euthyroid sick syndrome. Euthyroid sick syndrome is a very interesting syndrome that occurs in people that are very sick. They have presumed sepsis or they have multi-organ failure. We usually see it in patients in the intensive care unit. Now, these patients are not the typical patient. You shouldn't be drawing free T4s and TSHs in these patients and free T3s. Because if they have myxedema coma, your TSH is going to be off the wall. It's going to be very high. That's going to be diagnostic. So you shouldn't be worrying about things like that in this patient. But this patient has this thing called euthyroid